Okay, so interstitial lung disease, probably the most difficult topic, the most extensive topic in the field of pulmonary medicine. Definitely the most difficult topic for us, and even as during our degree, our super speciality. And to be very honest, interstitial lung disease forms a major chunk of what we actually see in our practice. Now, with improvements in diagnostic tools, imaging, we are really starting to see more and more of these cases. And now, especially with COVID happening, post COVID pulmonary fibrosis is just another form of interstitial lung disease. Okay, so interstitial lung disease actually, it's huge. So, but I'm not going to go into the very details. I'm just going to go through just the top, just to get you, give you some idea of what people mean, what people are thinking of, what when they are talking of ILDs. Okay, so what is meant by interstitium? So interstitial lung disease. So first thing you need to know, to understand ILD, you first have to understand what is the interstitium. So the interstitium is basically a connective tissue framework. It's a connective tissue framework abundant on the airways and arteries in the center of the lobule and around the veins and at the periphery. So you have here, like around the main bronchovascular bundle, you have the peribronchovascular interstitium. Near the lobule in the center, we have the centrilobular interstitium. Then you have the intralobular interstitium here, and then you have, these are the interlobular septae, and this is the secondary pulmonary nodule. Now, the importance anatomically of this secondary pulmonary nodule is that it is the smallest unit of lung structure, okay, that is separated by dense connective tissue septae. Okay, now in this particular diagram is an oversimplification here. In fact, if you were to look, you'll see only 1, 2, 3, 4, 5, 6, 7, 8, around 8 secondary pulmonary nodules, whereas in the real lung there may be over hundreds. Okay, so ideally they are polyhedral in shape and they measure around 1 to 1.5 centimeters. So this, even on gross section, this is probably one of the most easiest, most discernible structures of the lung, the secondary pulmonary lobule. Okay, then basic structure, framework, and composition consists primarily of your collagen and elastin fibers containing multitude of cells such as histiocytes, lymphocytes, dendritic cells, Langerhans cells, and mast cells. So this interstitium here that you see, all the different structures, it is not just a layer of connective tissue, but it contains a lot of other important elements and definitely very much alive. Okay. So now that we know what is an interstitium, what are the different anatomical areas of interstitium, let's go to ILD. So what is interstitial lung disease, ILD? So first and foremost, they are a heterogeneous group of disorders. They are non-neoplastic disorders, but they are heterogeneous. Okay, they are diverse both in range of acute, subacute, and chronic diseases. In range of presentation, they are diverse. In range of etiology, also they are fairly diverse. So the main pathology is that there occurs inflammation and fibrosis of the alveoli, distal airways, blood vessels along the respective epithelial and endothelial linings, and also the interstitium of the lung. Okay, so because of the fact that they also involve your airways, your blood vessels, not just the interstitium, these diseases are also synonymously called DPLD or diffuse parenchymal lung diseases. So this and this can be interchanged. In fact, this is the newer term and this is the older and more broader term. Okay. So epidemiology, the exact prevalence and incidence of DPLDs or ILDs are unknown. Most of the studies have suggested a prevalence of 81 per lakh population for men compared with 67 per lakh population for women. Okay. Classification, there are two main groups, two broad groups in which how you classify, the easiest way to classify them. One is primary ILDs, where the cause is unknown, and secondary ILDs, where the cause is known. So what are the primary ILDs? You have your usual interstitial pneumonia or UIP. Example of such UIP is called is IPF. NSIP, non-specific interstitial pneumonitis. Cryptogenic organizing pneumonia, COP. Respiratory bronchiolitis associated ILD or RBILD, AIP, acute interstitial pneumonitis or diffuse alveolar damage. It is more or less the same, also known as the Hamann-Ridge syndrome. Then you have desquamative interstitial pneumonia, DIP, and lymphocytic interstitial pneumonia, LIP. Now, what you have to remember is that all this UIP, NSIP, COP, RBILD, AIP, DAD, DIP, LIP, these are all derived from the histopathological appearance, which means, so this is basically the histological definition. So the pathologists have come up with their own classification, what on biopsy looks like UIP, what looks like NSIP, what looks like COP, what looks like RBILD. Okay, so for the fact that they have, these are all only based on the biopsy, the pathology. So obviously the etiology, there may be a number of diseases which will cause these. Like for example, UIP, if no cause is found on complete workup, you still have not found a secondary cause, then it will be labeled as idiopathic pulmonary fibrosis. Okay, so similarly for NSIP, if no cause is found, it will be labeled as NSIP. Okay, IPF and NSIP. IPF, if anybody says IPF, okay, if there's a clinical diagnosis of IPF, that means automatically you understand that the biopsy, if it had been taken, would have been a UIP. Okay, IPF can never be NSIP or COP. Okay, so coming to the secondary causes, known causes, you have sequelae of infection, most commonly tuberculosis. Then you have other bacterial, fungal, parasitic infections. Non-infectious causes, you may have hypersensitivity pneumonitis, pneumoconiosis, drug-induced, radiation-induced, sequelae of malignancies, and systemic vasculitis and other connective tissue diseases. Okay, in addition to that, association with diseases of inflammatory or unknown etiology, most commonly is sarcoidosis. Other connective tissue disorders such as systemic sclerosis, rheumatoid arthritis, PMDM, SLE, chronic eosinophilic pneumonia. Again, chronic eosinophilic pneumonia has multiple causes by itself. Then other causes, miscellaneous causes, can be histiocytosis, eosinophilic granuloma, lymphangioliomyomatosis or LAM, tuberous sclerosis, which may present with LAM or maybe by itself. Okay. Then another important heading which is not mentioned here but derives mention is your occupational and environmental ILDs. They include your silicosis, your asbestosis, most commonly seen in coal workers and those working in shipyards, hard metal pneumoconiosis, coal workers pneumoconiosis, berylliosis, talc pneumoconiosis, cirrhosis or arc welder's lung, stenosis or tin lung. So all these are basically secondary ILDs. So just to show you how vast it is, the classification of ILDs, you can have a look at this. You can take a screenshot. So, for example, like I said, UIP, usual interstitial pneumonia, which is a histopathological diagnosis. The clinical associations include IPF, connective tissue disorders, asbestosis, hypersensitivity pneumonitis, aspiration pneumonia, radiation pneumonitis, the Hermansky-Pudlak syndrome, or neurofibromatosis. So all these diseases can present with a histological or even a CT picture of UIP. Similarly for NSIP, there are a multitude of causes. Okay, so this is how extensive ILDs are. So I'm not going to bore you with this slide anymore. Now we go to diagnostic approach. Now, understanding the fact that the diagnosis, the etiology of ILDs is so vast, it is very important that we have a methodical history, examination, investigation, and a systemic way in approaching. Okay. So the hallmarks of ILD are progressive dyspnea and cough. That is seen with all ILDs, whether it is primary or secondary. There will be an abnormal chest radiograph, either on X-ray or CT, and of course, when you do a pulmonary function test, it will be impaired. Okay. So historically, they will present with progressive dyspnea and exertion, dry cough, and these symptoms are usually progressive over time. Now, In addition to the presenting complaints, it is important to take certain specific histories. For example, the past history, look for history suggest connective tissue disorders. Most of the time, especially in CTD-associated ILDs, you may have a history suggestive of the connective tissue disorders preceding the onset of the respiratory complaints and the lung pathology. However, at times, the lung pathology may be the first presentation of the connective tissue disorder. And a good example would be systemic sclerosis, especially limited disease. Limited systemic sclerosis may actually come to you, the patient may actually come to you with pulmonary complaints before you can even diagnose the cutaneous and other lesions. Hello, I'm taking class after 10. So occupational history, like you've already seen, there are so many ILDs which are associated with certain specific occupations. So occupation history should be thorough, detailed, especially since most of these ILDs, the pathogenesis, especially in occupational ILDs, is a continuous exposure, a long exposure. So there will be a huge latency period. There may be a person may have been working in a particular environment for 10 years, maybe 20 years back. There's been a latency of another 10 years before this thing. So if you don't take a detailed history of the occupation, especially in the past, you may miss out on occupational lung disorders. Okay, drugs and smoking history. For example, pulmonary Langerhans cells, histiocytosis, IPF, RBILD are strongly associated with smoking. Then other drugs, you have your amiodarone, nitrofurantoin, chemotherapeutic drugs. They are all associated with history of pulmonary with pulmonary fibrosis. So you have to take an important drug history also. Now, certain ILDs are familial, such as sarcoidosis, tuberous sclerosis, neurofibromatosis. They are all autosomal dominant, so it may be seen in other members of the family. And certain disorders like Niemann-Pick, Gaucher's disease, Herrmann-Caput-Lung are autosomal recessive. So taking accurate family history with a proper family tree is very important. Then, of course, gender. There are certain occupations which are more in men, certain occupations which are more in women. For example, if you see, if you're driving from Shillong if you're going up towards Mawplang and all, you would have seen just beyond Maungap, just before reaching Maungan and all, there are those areas with there are those stone quarries. And if next time if you've missed it, next time you go, you see who are the ones who are actually breaking those rocks into stones. It's predominantly women. That puts them at a very high risk of developing silicosis or something like that. So certain occupations in certain cultures are obviously gender biased. Okay, now lab is an interesting ILD in the sense that it is seen only in women. Lymphangiomyomatosis is a disease which is exclusively seen in women. Okay. So these are the history. Now, when you look at the way in which the ILD may present, so an acute presentation within days, symptom onset to symptom worsening of days to weeks. It may be allergy, could be AIP, can be eosinophilic pneumonia or hypersensitivity pneumonitis. Subacute presentation of week to months can be sarcoidosis, drug-induced alveolar hemorrhage syndrome, such as your good pastures, your Wegener's, and all that. I can't call it Wegener's now, GPA, granulosis with polyangiitis, cryptogenic organizing pneumonia and all that. Chronic presentation usually is IPF. Sarcoidosis can also present chronically. Your occupational ILDs, such as your pneumoconiosis and other connective tissue disorders. And episodic is eosinophilic pneumonia, especially when there is in the presence of all these other helminthic infections, hypersensitivity pneumonitis, and the other vasculitic syndromes. Okay, so this is basically what you need to find out, what you need to extract from the history, because getting all this information will help you narrow down your differential diagnosis before you proceed to investigating. Examination, most typical findings is the so-called bibasilar inspiratory Velcro crepitations, Velcro crackles. Okay, Velcro because it's like when you open and close the Velcro, the moment you open the Velcro, that's the kind of sound that you get when you auscultate it just in ILDs. Clubbing of digits also indicates advanced fibrotic disease. Cyanosis is usually, most of these patients may be absent at rest, but cyanosis can be induced by exercise, and that is a very sensitive test. Okay, then those with chronic diseases, long-standing ILD, they then may develop sequelae of the ILD per se, which is pulmonary hypertension, cor pulmonale, and all these congestive failure, and all these signs may then be manifested in patients with long-standing disease. Then secondary ILDs may also show signs of the underlying pathology, not the ILD per se, but the underlying disease causing the ILD. For example, the example I'll give you is CREST syndrome. CREST syndrome is a manifestation of systemic sclerosis. You have calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerotacty, and telangiectasia. So once you have once you identify a person on examination having these features, you're suspecting CREST syndrome, part of your workup should include a PFT and your HRCT. Okay. So to summarize, this is just a brief summary. If age is more than 60 years with ILD, usually it's most likely to be IPF. Okay. Youngers, think of secondary causes, for example, CTD. Women, LAM. Acute onset, you have your AIP, CTD, acute encephalic pneumonia, COP, HP, drugs. Smoking associated ILDs, your RBILD, DIP, UIP, PLCH. So UIP meaning also IPF. Okay, good posture syndrome. And interestingly, smoking is associated with a lower incidence of hypersensitivity pneumonitis. So it is negatively associated with hypersensitivity pneumonitis. Then certain specific exposures, then you think of occupational ILD or pneumoconiosis and also HP. HP most common in India is pigeons. Those rearing pigeons, those keeping pigeons, those even living, especially in cities. If you see in cities, say in Delhi, Mumbai, and all, you'll find a lot in a lot of these apartments. These pigeons are living. So those pigeon feathers, pigeon dung, and all that, those are the ones which contain the allergens for causing hypersensitivity pneumonitis. Okay, if there's any hemoptysis involved, you can think of the alveolar hemorrhagic syndrome, such as your good postures, your GPA, and all that. Okay, or you can even think of LAM. Arthralgia, then you think of CTD associated ILD, especially rheumatoid arthritis, etc. Skin rash, then you think of CTDs. Okay. Examination, remember typical velocrepes, inspiratory squeaks can be seen in COP. If there's clubbing, usually it's IPF, DIP, or IBD. Skin involvement is usually with sarcoidosis, connective tissue disorders, vasculitis, arthritis again. Then these are all the other examinations that you will have to look for to give you some idea of what are the, especially in secondary ILD, to try and identify what is the primary disease. So chest X-ray. Now, chest X-ray is usually diffusely abnormal, okay, and is often the first clue. However, like I've always said, chest X-ray is a very good screening tool, but in a normal chest X-ray does not always exclude ILD. It is a useful screening tool, but it is not a definite diagnostic tool. So now I have an extensive list of what can be seen on X-ray. Again, upper zone disease, you can think of radiation, sarcoidosis, Langerhans cells, histiocytosis, chronic HP, eosinophilic pneumonia, and all that. If there's an increase in lung volumes, then you can think of LAM, you can think of PLCH, neurofibromatosis. If there's already honeycombing, then most likely it'll be IPF, can be other diseases with UIP, such as CTD, drug-induced, radiation, Hermansky-Pudlak, and all that. Pneumothorax, most commonly with PLCH, LAM, okay, and neurofibromatosis. Curly B lines, lymphangitic carcinomatosis, LAM, PH can be actually a manifestation of the cor pulmonale due to the ILD. Lymphadenopathy is seen with sarcoidosis, can be lymphoma, lymphangitic carcinomatosis, and others. Pleural diseases, again, LAM, lymphangioliomatosis, and LAM causing chylous effusion. Okay. Eggshell calcification, classically silicosis, especially of the mediastinal nodes, but can also be seen post-radiation and also sarcoidosis. Again, like I said, extensive. It's an extensive list, and but again, this is on X-ray, not very specific. Okay, it's just sensitive. You can see that any abnormality can cause for any abnormality. Take an example. Initial chest X-ray at presentation was when the patient had only complaints of cough and exertional breathlessness. Okay. Here, if you look at this chest X-ray, otherwise looks essentially normal. Now, with progression in time, his symptoms worsen. If you look at this chest X-ray, first thing you notice is that compare this and this, you'll notice that there is already some reduction in lung volume. This is quite apparent here. Then, as the disease further progresses, then on X-ray you can notice again. Now you're getting a lot of these streaky opacities. Okay. All these linear opacities present in the bases, and over time there's marked reduction in lung volumes, there's extensive fibrosis. Okay, you can see the diaphragm pulled up both sides, very small hemithoraces. Okay, so this is basically almost like end stage IPF. So what happened was that this patient essentially eventually underwent open lung biopsy and was found to have a UIP pattern on the biopsy. Was started on treatment to drugs and even underwent lung transplant, but subsequently succumbed to the disease almost 6 to 7 months after lung transplant. Okay, so this is basically just to show you at that X-ray that the patient may be symptomatic, but the X-ray may be, initial X-rays may be normal. So do not depend only on your X-ray to try and look at the diagnosis. Okay. So HRCT of chest, again, it is the imaging modality of choice nowadays. In fact, with the latest classification and latest definitions, HRCT has become very sensitive and very specific to ILDs, to the extent that if it is a typical pattern, then it is no longer recommended to do a biopsy. We can give a definite diagnosis based on the HRCT picture alone. So for example, here, this is a normal HRCT of the chest. This is at just below the level of where the trachea bifurcates into your right and your left. Okay, so here you can see that this is the horizontal fissures on both sides. You have your vessels, this is your bronchiole, and these are your bronchial vessels. Okay, now when we look at ILD, CT picture is very, very stark. Now for a similar person with UIP on X-ray, where we really do not see anything, your CT has already shown so much. There's a lot of, this is what we call as the honeycombing. This is honeycombing, okay? There's a lot of interstitial thickening, there's interlobular septal thickening, okay? There's a lot of honeycombing, there's traction bronchiectasis here, there's already a loss of alveoli here. So this is what we can see on CT. So CT provides a very detailed images of your lung, which we can never get from X-ray. So that is why HRCT now has become the imaging modality of choice when we are talking of interstitial lung diseases. Okay, so when we look at HRCT, again, if there's interlobular septal thickening, honeycombing, traction bronchiectasis, you can think of connective tissue disorders, you can think of IPF, asbestosis. Usually this is what we call as a UIP pattern, but it's not complete. Now for UIP, for NSIP, even in addition to biopsy, even your CT, there are definite criteria, but all those are already quite extensive, so I'm not going to put them here. Okay. More of alveolar involvement, ground glassing and all, you think of NSIP, you think of COP, you think of AIP, DAD, okay. Presence of more nodules, you think of pneumoconiosis, rheumatoid arthritis or sarcoidosis. And if there are a lot of cystic spaces, you think of LAM, PLCH, LIP. Cystic ILD, again, on CT, if it is cystic, clinically, think of pneumothorax, okay? Because most of the time, there's a very high chance that if the cyst structures, then they may develop pneumothorax. So these are just basically the broad divisions when we're looking into the CT of patients with ILD and what are the differential diagnoses. Now, pulmonary function tests, again, what we will definitely get is a restrictive defect on spirometry. But like I've said before in previous classes, spirometry alone cannot help in differential diagnosis. However, once we have a definite diagnosis of ILD, spirometry is useful in functional assessment over time, response to therapy, Okay, then spirometry becomes more useful. But to diagnose ILD, we cannot use spirometry. We need a body plethysmography if we're looking at pulmonary function test. Because body plethysmography will provide you with your total lung volumes, your tidal volumes, your vital capacity, total lung capacity, which will all be reduced in your in patient with ILDs. And then another thing is pulmonary compliance. Reduction in pulmonary compliance may be seen before there's a gross, before there may even be a gross abnormality in the other volumes. Hello. Hi, Mary. Actually, I'm taking a class. Yeah, I'm taking class right now. So I'll call you up after 10. Okay. So in addition to your spirometry and your body box, your static lung volumes, you can also do the diffusing capacities. There's a reduced DLCO, diffusing capacity of carbon monoxide, and arterial hypoxemia, which may not be present in the early stages of ILD. Now, lung biopsy. Often, before the advent of HRCT, before HRCT became the diagnosis or diagnostic modality of choice, again, diagnosis of ILD required biopsy. Like if you've seen, the classification of primary ILDs is based on biopsy, because all these classifications were made before the advent of the technology of HRCT. But now, with HRCT becoming so sensitive and so specific, lung biopsy is only required when the findings are atypical. The CT is atypical, or there's a mismatch. There's a disconnect between your CT findings, the symptoms, okay, or you want to exclude an infection, okay, or after all the non-invasive investigations, you've done your spirometry, your lung function, your blood tests, your CTs and everything, you're still not clear of what the diagnosis is, then in that case, you may go ahead and do a lung biopsy. So lung biopsy, usually the procedure of choice again is a surgical or open lung biopsy. It achieves three purposes: it establishes a precise diagnosis, it assesses the extent of inflammation, fibrosis, and also identifies histological patterns of IAPs of the interstitial pneumonias. The reason why it's preferred is because when you do a surgical lung biopsy, it is an open lung. You open up the chest, and so you can take a large chunk of the lung tissue as much as required. Because pathologists are very fussy people. Whatever you give them, they'll ask for more. Okay, I think probably maybe they drink a lot of Pepsi or something, because they'll mange more. They'll always ask for more. They'll never be happy with whatever you give. So surgical biopsy, you can give them a huge chunk. With that, they'll be happy. But the problem with surgical biopsy, surgical lung biopsy, open lung biopsy, is it is quite a morbid procedure. It is under general anesthesia. You'll have to. It is more or less a surgical procedure. Okay, it is a cardiothoracic procedure. You need a cardiothoracic surgeon to take that. Patient will need to be admitted, post-op, there may be complications. Okay, it is a major procedure. So how do we overcome that? Of late, we now have what we call as cryo-TBLB, or transbronchial lung biopsy, which is done by bronchoscopy. It is not a surgical procedure. And what we're using here, we call it cryo, because instead of, if you remember the last class, I had shown you a biopsy which I had done where I was using a biopsy faucet. In cryobiopsy, what we're doing is, instead of a biopsy faucet, we use a cryo probe. So this is just a metallic probe, a probe where the tip of the probe is cooled to -70 degrees, okay, by using liquid nitrogen. And then, so what happens is this: when this tip touches the tissue, it immediately freezes the tissue around. And then when you pull out, whatever is stuck to the tip, okay, that gets pulled out along with it. So it is not a bite biopsy like a faucet. Rather, it is just like you're freezing the tissue near you and then you're just tearing it off. Okay, so here, compared to a faucet, because through a bronchoscope, the faucet is not very large. So whereas with cryobiopsy, you can get a much bigger chunk of tissue, and which is comparable to a surgical lung biopsy, but of course, the patient need not undergo your opening of your rib cage or anything like that, opening of the thoracic cavity. So this is basically, this was a photo which was taken by me. This is a photo from my department in AIMS. This is where 3 of my consultants, the head of department and 2 assistant professors, were performing a cryobiopsy. So what they're doing is, the patient is under general anesthesia with a rigid bronchoscopy. Here, there's a rigid bronchoscope, and through the bronchoscope, one of the consultants here, Dr. Karan, he is using a flexible bronchoscope. So through the rigid bronchoscope, which goes all the way up to the lower part of trachea, we then push the flexible bronchoscope. Okay, so this is what we call as a Fogarty catheter, and this is the cryoprobe. So Dr. Hadda here is the one actually manning the cryoprobe. So this is a small probe you can see here, which is this. So through this probe, we have liquid nitrogen for flowing. So that cools the tip to around minus 70 degrees. So what he does is he will insert it all the way into the distal segment, start the nitrogen, liquid nitrogen, wait for 20 seconds, and then sharply pull out, and then you get a good chunk of tissue along with it. Now, the only problem with cryobiopsy is that there may be high chance of bleeding because you're not taking a neat bite, you're taking a tear. You're tearing the tissue. So obviously, if there's any blood vessel nearby, that blood vessel also may be torn along with it. So that can cause a lot of bleeding, which is why we have the Fogarty catheter. Okay, so the HOD, Dr. Anand Mohan, he's the one manning the rigid bronchoscope, and at the same time, he's also holding on to the Fogarty. So the moment the probe comes up, your cryo probe comes up, then you have the Fogarty, which is placed here. It occludes that segment. So even if there's any bleeding, we wait for some time, allow for the bleeding to stop, allow for hemostasis to occur, and then we can deflate this after around 2 to 3 minutes. The advantage of this is that even if there's any bleeding, when you block it like this, it will not pass into the other segments of the lung. Otherwise, the bleeding may become so significant, it may flood the other segments of the lung. So this is basically how we do a cryo TBLB or cryo transbronchial lung biopsy. Okay. So now I hope you understand that lung biopsy now is not clearly warranted. You don't have to do a lung biopsy for all cases of ILD, except, of course, when you are not sure of your diagnosis, there's some discrepancy, there's some disconnect between your clinical, radiological, and other investigations, then you can go ahead with a lung biopsy. Otherwise, with the advent of CT, we don't really need to do a biopsy anymore. Okay. So other investigations will be that you can think are your complete hemogram, where you look for eosinophilia, you look for anemia. If there's anemia messages, especially if there's an acute blood loss, acute HB drop, you can think of diffuse alveolar hemorrhage. Then you look at leukopenia, and then of course all your antibodies. You look at your connective tissue and other vasculitic syndromes. Okay, so that's basically with the investigations. Coming to management, of course, treatment options for ILD are limited, and most of the time, ILD usually will be progressed on relentless or despite any major medications or anything that you can give. It is a very distressing, depressing disease for everyone, for the patient, for the doctor, because sometimes we've seen that with therapy, patients will fail. They are not improving, nothing, and these will just keep on progressing. So it's a chronic therapy, it's a permanent disease, it's a chronic disease, and at times a progressive disease. However, this is important. You have to be very sure of what kind of ILD you're doing. You have to be sure of what kind of ILD you're dealing with. The reason for this is that, yes, if it is something like IPF, if you know it's IPF, then you know that the prognosis is not good. The disease may progress despite all your best efforts. However, certain ILDs, like your secondary ILD, secondary to your vasculitic syndrome, secondary to the connective tissue disorders, they respond very well to therapy. And certain therapies also will be guided based on whether they are secondary or primary ILDs. So having a definite diagnosis is very important with regards to ILD, because that will dictate, one, how you prognosticate your patient and their response to therapy. Okay, and a number of drugs are used in the treatment of ILDs. Okay, so you have your anti-inflammatories, antifibrotics, antioxidants, then anti-apoptosis agents, anti-angiogenesis agents. Okay, it's a huge list. Then in addition to that, you have your supportive and symptomatic drugs such as oxygen, vasodilators, diuretics. Basically, if they have they develop congestive failure. Then your antibiotics, and of course, in the end, you have your rehabilitation, which is your pulmonary rehabilitation, nutritional rehabilitation. Okay, and among the surgical modalities, probably the one with the maximum benefit is lung transplantation. Okay, ILD has now become the #1 disease for which lung transplantation is being done. And the advantage of ILDs is that you need not transplant both lobes of the lung. Transplant, just doing a single lung transplant is enough when we're dealing with ILDs. Okay. But of course, with ILD, with lung transplantation, you will always have the other complications with any transplant. Not just lung transplant, you have your opportunistic infections, you have the chance of rejection, okay, and chronic immunosuppression of the patient, putting him at risk of other infections. So that is the flip side of lung transplantation. But of course, lung transplantation offers the best, one of the best outcomes. And in India right now, we've had two major centers, Bangalore and Chennai, which have performed successful lung transplants for a multitude of disorders, including ILD. Okay, so when it comes to treatment, that list is big, I know, but if you have to know two drugs, if you have to know anything, just know these two drugs. First one is pirfenidone. Pirfenidone is 5-methyl 1-phenyl 1,2,1 hydride pyridone. Okay, so what is this? It's basically an anti-fibrotic agent. It inhibits the progression of fibrosis, and pirfenidone has been shown to reduce the disease progression, which is reflected by better lung volumes. That means the reduction in lung volume is arrested. There's improved exercise tolerance and better progression-free survival. So in addition to pirfenidone, the second drug which has come, which is also very effective now, is nintedanib. Nintedanib it's a danib. If it is a danib, then you know it is a tyrosine kinase inhibitor. Okay. It's a nib, not a danib, basically is a nib. All nibs, a majority of all nibs are tyrosine kinase inhibitors. So nintedanib basically targets PDGF, targets VEGF, targets your FGF. Okay. So here with nintedanib also, what we've seen is that there's significant reduction in the decline of lung function, with fewer exacerbations and preserved quality of life. In fact, these two drugs now form the backbone when we are talking of treatment, medical treatment for ILD, especially IPF. You can either start with one and then you can even add on the second drug. Usually our first, initially what we do is we start with pirfenidone, and if the patient responds and there's significant improvement with pirfenidone, we leave it as such, try to maintain the patient on pirfenidone, and but if there's progression, then we can even add on nintedanib to pirfenidone. Or the other things is some people, by personal choice, they prefer nintedanib. Nintedanib has only recently been available in India. Pirfenidone has been there for a few years now, but nintedanib has only recently been available in India. So now that it's available, like for me personally, I use pirfenidone a lot. I prefer using pirfenidone because I have more experience with it. Nintedanib, I've never had any experience. Prior to 2020, we've only used in one patient, and that was a time when it was not even available in India, and this patient happened to be the father of one of the faculties in AIMS. So, and this faculty was senior faculty in the Department of Pharmacology. She was also part of the board of the Drug Control Authority of India. And so for our father, she managed to get it on humanitarian grounds from Germany. That was the time when we actually got the parent molecule, the original molecule from Boehringer in Germany. So that was the only time prior to 2020 that we've used nintedanib. But now nintedanib has come to the Indian market. It's quite cheap. And pirfenidone especially, we're using it a lot in your post-COVID fibrosis, post-COVID lung fibrosis. Pirfenidone has been found to be, even my own experience with pirfenidone, we've used it in almost 5-6 patients here with significant improvement in their exercise capacity after getting fibrosis due to COVID-19. Nintedanib is one drug which I've not used, but again, a lot of other pulmonologists and all have been using nintedanib also, both for IPF and also for COVID-19. Okay. So basically, to summarize, this is basically a diagnostic algorithm. You have your clinical features, your breathlessness, vagocrackles. You do a CT. You're suspecting ILD. You do a CT or a chest X-ray. If they are bilateral reticular and reticular nodular military infiltrates, basically any patterns suggest ILD. Then you do a PFT. If there's, in addition, there are features to suggest PFT. Then we do a HRCT. You look at the involvement. If there's extensive involvement, the UIP pattern, then you think of an IIP, start treatment based on your whichever drug you want to use. Now, when it comes to IIP also, the one thing you have to know, there are so many drugs available. Steroids also form a backbone. Now, the thing is, if there's extensive fibrosis, if there's so much of honeycombing, traction bronchiectasis, there's more of fibrosis than anything, then steroids will have no role, because steroids, they're more when there's evidence of active inflammation. So you have your granulomatous, you have your organizing pneumonia. That is where steroids play a major role. When it's already fibrosis is already well established, then steroids will have no role, and there's no point giving it. Just may cause more harm to the patient. Okay, so if the response is good, you continue the treatment. If there's pro, then you can think of palliation. Okay, so just to summarize and just to give you a brief highlight. Now you remember your UIP, your DIP, RB, ILD. Now, if you look at the mean age of onset UIP, we're talking about UIP and clinically UIP on CT on and histo, and clinically IPF. Mean age of onset is usually in the 7th decade. That means the 60s. DIP is younger. Onset is insidious. Okay. AIP is the only ILD which occurs acutely. Okay. Acute institutional pneumonitis or the Hamann-Ridge syndrome. This is the only acute ILD that we have. Most of them are subacute or chronic. Okay, now response to steroids, again, NSIP has a good response to steroid because primarily the NSIP pattern on CT or biopsy is most of the time secondary to connective tissue disorders or vasculitis. So that is why this has a good response to steroids, because the underlying pathology, the underlying disease usually is very steroid responsive, whereas the organizing pneumonia have the best response to steroids. Okay. Complete recovery with NSIP or with COP. Okay. UIP, IPF is primarily a progressive disease despite our best efforts. So this is basically just a brief overview. I'm just touching on a brief overview of all the ILDs. This is basically what at your level as MBBS students you need to know. If anybody asks you questions on ILD, you should at least be able to tell them what is an ILD, what are the ILDs, what are your primary, what are your secondary ILDs, what are the investigations of choice, when will you do a lung biopsy, and what are the drugs that you may use when treating ILDs. Okay, so that's it with today's lecture. So by Monday, if you can just tell me, there are 2 classes remaining after this. So by Monday, if you can just give me a list of at least 2 to 3 topics that you would like me to cover in the next 2 classes, either for revision or if there's anything new which I may have missed, please do let me know. And then I'll see you all next Saturday. Okay, thank you.